I'm Dr. Lucinda Bateman. Today I want to talk to you about sleep disturbances and the impact on ME, CFS, and fibromyalgia. Before we talk specifically about sleep, let me tell you how it fits in. The general principles of supportive management for ME, CFS, and fibromyalgia come from this formula. First, you must address all conditions that are associated with your illness. This means you should complete a good medical workup with your primary physician and make sure that all of your other medical problems are under very good control. Second, it's important that you learn how to pace your activity level. This is to reduce symptom escalation from doing too much. You want to stay active, but you want to know how to manage your activity so that symptoms are calm and less aggravated. Then we address the major aspects of illness. And in most cases, this includes reducing pain, achieving restorative sleep, reaching a calm place in your mental health, and trying to maintain a certain amount of fitness as illness permits. So you'll see that sleep is a very important and pivotal part of management, including the front place on the table legs that hold this table up. You can see from the 2010 fibromyalgia criteria that sleep contributes to making the diagnosis, because you can score up to 3 points needed to qualify for the fibromyalgia diagnosis based on disturbed sleep. The ME/CFS clinical diagnostic criteria also put unrefreshing sleep and sleep disturbances as a primary core symptom of the illness. So what is unrefreshing sleep? We know that sleep disturbances are common. They're included in all the case definitions and criteria for chronic fatigue syndrome, ME/CFS, ME, and fibromyalgia, and present in more than 95% of people diagnosed. Sleep is abnormal in almost every way in somebody across this spectrum. It can be abnormal in quality and abnormal in duration and timing. Unrefreshing sleep is consistently reported and includes sleeping too much, too little, trouble falling asleep, trouble getting back to sleep, frequent awakening, trouble waking up after finally getting to sleep, and the need for naps, as well as developing very irregular sleep cycles. There may be a number of illness aspects that we can identify that insidiously disturb sleep. These relate back to what is called central sensitivity. This includes the pain amplification of fibromyalgia that can disrupt sleep, all the sensory amplification of ME/CFS and fibromyalgia, which includes sensitivity to noise, bright light, and temperature extremes. Sometimes the central overload of post-exertional malaise from doing too much unravels normal sleep. You might feel tired but wired or too exhausted to sleep. And one of my patients calls this over-signaling. That is part of his post-exertional malaise. All of these things can disrupt sleep. In a Dutch study of more than 300 chronic fatigue syndrome patients who had undergone polysomnography, those with primary sleep disorders such as obstructive sleep apnea, restless legs, or narcolepsy were excluded from this study to see what the intrinsic problems with sleep were in ME/CFS. And you can see from this graph that they fell into at least 4 different categories. And maybe one person could be in any of these categories at a different point in their sleep. Sleeping all the time and increased REM sleep, sleep that is characterized by lack or diminished REM sleep, that's dreaming sleep. Those who have multiple arousals per hour, sleeping lightly and waking up frequently, or those who just can't get to sleep at all and have reduced REM sleep. And these are different ways that your sleep can be disrupted, and it might occur in different ways at different times. How do we observe and monitor our sleep? The gold standard is polysomnography. And it's expensive and good for some observations, but one of the problems with polysomnography is there is a high amount of sleep artifact. And that means that when you go to the sleep lab, you sleep restlessly, you're in a strange place, you're wired up and people are observing you. So maybe it doesn't reflect your normal sleep patterns. But it is possible that the sleep patterns that are disrupted in ME/CFS and fibro are very much like what we call sleep artifact on polysomnogram. So most of the information about sleep stages and the quality of sleep are minimized in the assessment of polysomnography. We're mainly looking for primary sleep disorders. You can also have a home sleep study that is newer and collects most of the variables of polysomnography except the EEG leads that can be done in your home if your insurance will cover. Still less expensive is to have an overnight pulse oximeter that you can just put on your finger and it will record your oxygen values through the night. This is good, but it only picks up those people who have a drop in their oxygen overnight or develop hypoxemia. So much can be missed with just an overnight pulse ox. You also can monitor your own sleep with the Fitbit or other self-monitoring device or an Oura Ring, and we're going to talk about that later in our slideshow. So polysomnography is really good at revealing primary sleep disorders. It's not diagnostic for what we think is the main problem in ME/CFS and fibromyalgia, and those are increased alpha waves. Those are waves that are present when you're just barely asleep or dozing. We know that decreased delta sleep or deep sleep is present, and sleep is fragmented and often delayed in onset. And those are things that are difficult to pick up on polysomnogram. This is a picture of brain waves or EEG patterns when you're asleep and awake. And the first yellow star is showing what alpha waves look like. And these are really when you're feeling drowsy and shouldn't be present when you're sleeping. But particularly in fibromyalgia studies, we can see what is called alpha wave intrusion, or the presence of alpha waves during sleep. So part of the brain may not be resting and getting into the right kind of sleep. And we also see less slow wave sleep. Those are the big waves where the second yellow star is. And those are stages 3 and 4 of sleep, and we don't see enough of that in these disorders. Now, we should refer to primary sleep disorders so we know what they are. These are usually central sleep apnea, which is a diminished drive to breathe from the brain, obstructive sleep apnea, which is when something blocks air movement, reducing the oxygen level or the rate of breathing. And then there are several movement disorders, periodic leg movement and restless legs that can make it difficult to sleep. And the fourth primary sleep disorder is narcolepsy. These cause severe sleep disruption, somnolence, fatigue, and other symptoms. And we know that these disorders are more common in people with ME/CFS and fibromyalgia than the general population. So it's important to identify them and take care of them. I want to show you how to read a hypnogram. Hypnograms are basically diagrams of the stages of sleep. And these are 2 examples below. On the left is more of a cartoon example. That is a graphic representation of sleep stages. So if you follow the line from the left toward the right, first the patient is awake and then goes down through the stages of sleep into the blue, which is deep sleep, then gradually comes up to some REM sleep, which is red, then goes down into deep sleep and maybe a little bit up and then down and then up to REM sleep. And as the night progresses, there's less deep sleep and more REM sleep in the classic example of a hypnogram. On the right side of the screen is an actual, more of a diagram that would be seen on polysomnography, but it still shows the same principle, and that is when you start at the left, the patient's awake, and within the first few minutes, go down to light sleep, and then into deep sleep and deeper sleep, then come up for some REM sleep, and down for deep sleep, up for REM, maybe a brief awakening, and you can see that progress through the night. And usually, one of the reasons I think that people remember their dreams is the presence of REM sleep near awakening. And that is a normal sleep pattern. Look at this hypnogram in a patient who has obstructive sleep apnea. On the left is the hypnogram of the patient's sleep wearing CPAP. You can see that they're awake and then light sleep and go down into deep sleep, up for some REM sleep, down into deep sleep. That's a normal pattern. On the second half of the night, the CPAP was removed, and you can see that someone with obstructive sleep apnea, in the absence of that assistance for opening the airways, they go in and out of awakening, light sleep, awakening, light sleep, a little bit of REM, and no deep sleep. You can see why people with obstructive sleep apnea have a lot of daytime somnolence, and why improving the obstructive sleep apnea with CPAP can really help them feel better during the day. Because we're dealing with illnesses characterized by fatigue, both fibromyalgia and ME/CFS, it's very important to distinguish between fatigue and somnolence or sleepiness. They're not exactly the same thing, and it's important to distinguish them because sleepiness is probably more treatable, and it's usually caused by some kind of sleep deprivation or sleep disturbance, whatever that might be. It may be often caused by medications, and sometimes an active illness, particularly an infection like mononucleosis, can make people feel very sleepy. But sleepiness is different than the pervasive, heavy illness fatigue that is characteristic of ME/CFS and fibromyalgia. In other words, there's the potential to reduce almost all somnolence, and it's worth trying to understand why you're sleepy during the day. Now, you can read your own hypnogram if you have undergone polysomnography, but remember that it represents only one night and might not represent your normal sleep stages when you're in a pattern of sleeping in the comfort of your own bed. You know, as we said, people sleep lightly in the sleep lab. So really, this is the best way to understand your sleep is to find out how to record your sleep many nights and as often as you would like, so that you can understand the quality of your sleep and maintain better control. This is why we have been recommending some kind of a self-monitoring device, such as a Fitbit, to get in the habit of recording your sleep. You can record the amount of time you sleep, document the number of disruptions. It's not quite as good at analyzing what the disruptions are from, and it only estimates sleep stages, but it's still valuable information. Let me show you some examples. On the left is an example of the recordings of sleep in a normal person, and on the right, someone who has obstructive sleep apnea. On the left, you can see the blue line is, the dark blue line is the sleep, and the light blue lines are disturbances, and a pink line is when the subject actually awakens. Let me show you the next slide closer up of the patient with obstructive sleep apnea. You can see that the dark line is interrupted many, many times during the night by those light blue disruptions, making the total amount of sleep diminished. So this is a person who benefited a great deal from doing self-monitoring, which led to going for polysomnography and treatment of obstructive sleep apnea. Now, this is a picture of another self-monitoring device called the Oura Ring. These are available if you want to buy them online. You just go to auraring.com. And what we really like about the Oura Ring is it's very comfortable. You can wear it on your finger, and it records It presents information regarding your activity, your sleep, and your readiness, trying to help you get a balance of how much activity you engage in and the quality of your sleep, resulting in your readiness to feel well and have a good day. Let's look at the information on sleep. It's very similar to the Fitbit. On the top is the longitudinal amount of sleep day by day, so that you can see your the sleep stages as they progress night after night. In the middle of the screen is the hypnogram, and then there is information below about deep sleep, REM sleep, light sleep, and awake sleep. Here it is closer. So you can see that this person tried to go to sleep. It was a little awake, then REM sleep, light sleep, REM sleep, light sleep, a little bit of deep sleep as it progresses through the night. The second one shows that the person went to sleep but woke up 4 times before finally getting into deep sleep, then light sleep, and toward the end of the night, REM sleep. So yours may vary for a number of reasons, but you can take your hypnogram with self-monitoring devices and work on reducing the number of interruptions in sleep and getting an adequate number of hours of sleep. You can also assess your interventions if you look to see how these improve over time. Unrefreshing sleep may come from sleep that is abnormal and not restorative. Dysregulated sleep of any kind is insidiously destructive over time. It contributes to pain and fatigue of these illnesses. So you should use every healthy method possible to achieve restorative sleep. You should develop skills in relaxation and understand your medications. One of the most important things in talking to your doctor about sleep and somnolence is to communicate clearly about what is happening with your sleep. This is an example of a 0 to 10 scale we use in our clinic to estimate how much this is impacting you or concerns you relative to some of your other symptoms. But that's not very much compared to what we do in our more detailed intake. You can see, instead of one question about sleep, we ask a whole list of questions about sleep and ask the patient to tell us if it's frequent and severe, whether they can't go to sleep, the sleep is restless, etc., as you can see going down that list. It might not help you to understand your sleep disruptions, but your doctor might know what to do if they could see a very detailed description of how your sleep is disturbed. This is an example of someone who has trouble getting to sleep. They wake up too early, they can't get back to sleep, mostly insomnia. And that might be a different approach than this patient who has too much sleep, needs to take a nap, needs too much sleep, and even though they're sleeping all the time, the sleep is unrefreshing. And this person has mostly restlessness during sleep, restless legs, leg cramps, jerking, and that wake them up from sleep and render them unrefreshed in the morning. So this is a good way to detail the nature of your sleep disturbance and get your provider to help you make changes. Now, you should be addressing reversible sleep disturbances, and this is a hard one, but you should, reduce caffeine, alcohol, things that are stimulating like decongestants and stimulants. You might be surprised that, paying attention to those things might help you have much more restful sleep. Try not to do things that activate your brain just before sleep, such as looking at bright screens or watching an active movie on TV. It's better to let the brain calm down and not have that kind of stimulation right before trying to go to sleep. You should also learn and become skilled at deep relaxation techniques. They can be very effective. The more difficult it is for you to do that, the more important it is for you to learn how to do it. You should treat movement disorders, you should treat obstructive sleep apnea, and you should definitely address central sleep apnea because that is often related to medications that suppress and block the signaling for your respiratory drive. This happens most commonly on opioids and benzodiazepines. So these are some tips that you can think of in trying to improve your sleep. Improve your sleep hygiene. That means, you and only you can work on the timing and the environment of your sleep so that it's most conducive to relaxing and going to sleep. You should identify medications that might adversely impact sleep, as we discussed. You want to be as active as you can during the day and not take long naps so that within the confines of your illness, you can become physically tired and your body's ready for sleep. You want to minimize sedating drugs during the day so you can accomplish that. And when you're trying to treat sleep, try to identify the cause of your sleep disruption rather than just drugging yourself to sleep. So if you're having trouble with sleep onset, your approach is going to be to wind down and establish cycles, maybe short-acting medicines that can initiate sleep. If your problem is light sleep and frequent awakenings, a medication to put you to sleep that only lasts 2 or 3 hours might not be the best for you. You might need to think about longer-acting medications or reducing interruptions during the night. If you're someone with early morning awakening, this could be medication rebound or withdrawal. Maybe you've had too much sleep. And sometimes we associate early morning awakening with depression. But don't give up, because achieving restorative sleep is a constant battle. But the more restorative your sleep is, the more you'll feel improvement in your fatigue, cognition, pain, and possibly even your mood. Let's talk a little bit about medications that can be used to improve sleep. The drugs on this slide are drugs that are longer acting, more likely to sustain sleep. And it's interesting because these are not really sleeping pills. So we say they're used off-label for sleep. But they are safe for long-term use because they're approved for some other kind of a chronic condition. This includes the tricyclic antidepressants like amitriptyline and doxepin. We use other antidepressants as well, like trazodone and mirtazapine. Anticonvulsants can make you sleepy. These are anti-seizure drugs. The ones we use often for pain and migraine are gabapentin and topiramate. Benzodiazepines can be used for sleep. Clonazepam is very long-acting and is sometimes used for treating restless legs or myoclonus. And then we have neuroleptics, which are major tranquilizers for mental health problems. But because they're very sedating, they can be used very effectively in low doses for sleep, especially sleep disrupted by anxiety. These longer-acting drugs can give you hangover symptoms in the morning if you don't figure out how to finesse them. So you want the doses to be low so that they don't, give you too much sedation, just enough. And sometimes they need to be taken earlier so that they start to kick in around the time that you're ready to go to bed. You really should choose a sleep medicine from this category based on your other comorbid conditions and the nature of your sleep disturbance. So if you need something for anxiety and sleep, it might be one drug. If you have migraines and you're not sleeping, or if pain is your main disturbing feature of sleep, you can tailor the long-term sustaining medication for sleep so that you accomplish more than one thing. There's no perfect medication for sleep. Now, there are drugs used for sleep that are actually FDA-approved drugs for sleep, or hypnotics, and sometimes we call them sleep initiators. Usually these aren't quite as good at sustaining sleep all night if there is a continuous disruption of sleep, such as pain. You've probably heard about those, though. They're not specifically approved for fibromyalgia or ME/CFS, but they are approved for insomnia, which can be a part of these illnesses. Zolpidem, which is Ambien, Zaleplon, Isoprolol, which is Lunesta, and sometimes benzodiazepines. In general, chronic daily use of these medicines is discouraged, and so they're really not the best choices for chronic daily insomnia. The problem is tolerance and dependence often develops, which means that it doesn't work as well, but you have trouble getting off of it because you have rebound insomnia when you try to stop. They're really better for sleep initiation than to sustain sleep all night. And they're really the best used as a rescue med when you really just have a real urgent problem with sleep rather than nightly use. There's a new drug that is interesting. It is not available in generic form at this time, called Belsomra. This is an orexin receptor antagonist, and I've had some good luck using it in my clinic, especially in people who aren't on a lot of other medications and don't tolerate many side effects of medications used for sleep. It may prove different than other sleep agents, but we'll see. It's fairly new. So in review, this is the table leg. The table and the table legs, our approach to management. And there is sleep right in the front table leg, that is very important to achieve, along with stabilizing your stress and reducing the severity of your pain and trying to work on helping your body become more healthy and strong in the face of a very difficult illness. Well, I hope that was helpful for you. I want to thank you and wish you good luck in your self-management and in your discussions with primary care providers. Remember that we have other classes that might be helpful, including making the right diagnosis, how to deal with activity intolerance, pacing, and post-exertional malaise, addressing widespread chronic pain, dealing with cognitive impairment, and how to understand and treat orthostatic intolerance.